Welcome to This Week in Surgery Centers. If you're in the ASC industry, then you're in the right place. Every week, we'll start the episode off by sharing an interesting conversation we had with our featured guest, and then we'll close the episode by recapping the latest news impacting surgery centers. We're excited to share with you what we have, so let's get started and see what the industry's been up to. Hi, everyone. Here's what you can expect on today's episode. This week's guest needs no introduction. Kara Newbury, ASCA's Director of Government Affairs and Regulatory Counsel, is here today to share what ASCs need to do to start acting on CMS's 2023 Final Medicare Rule. Kara walks us through reimbursement rates, the covered procedures list, the complexity adjustment policy, and more. In our news recap, we'll cover 5 trends ASCs need to know in 2023, how a hospital recovered $35,000 worth of lost instrument in 9 months, tips for adopting new tech in 2023, and of course, end the news segment with a positive story about a doctor who saved 2 lives during a half marathon. Hope everyone enjoys the episode, and here's what's going on this week in surgery centers.
Kara, welcome to the show.
Thanks for having me.
Appreciate you joining us today. And I know that many of our listeners are going to be familiar with you and your name, given the work that you do in this industry and advocating for this industry. But for those that may not know you, can you give us a little bit of an overview on yourself and the work that you do?
Sure, absolutely. So Kara Newbury, I work for the Ambulatory Surgery Center Association. I've been with ASCA for more than 11 years now, and my current role is Regulatory Counsel and Director of Government Affairs. So I'm basically spearheading all of the advocacy work that ASCA does.
Fantastic. And we're excited to have you on in general, but super excited with this timing. With CMS publishing their final ruling just a couple weeks ago, I believe, and wanted to ask you a couple questions about that. You know, there's folks that we talk to trying to interpret and understand different pieces, and so if it's okay, I wanted to ask you a couple kind of clarifying questions as it relates to the ruling. So to start, can you give our listeners a quick overview of the increases to Medicare reimbursement rates for 23?
Sure. So I'll just start out by saying, because usually I'm called a Debbie Downer when I give some of these updates. So, it was slightly more positive than was in the proposed rule. So I have to start out, I guess, with a little bit of a positive. So the effective update for ASCs is 3.8%. Obviously 3.8% is nowhere near what we know our facilities are facing in terms of increased costs, staffing costs, supplies, overhead. So, we're disappointed that it wasn't higher, but it was, like I said, at least a little better than the 2.7% effective update that had been in the proposed rule.
Got it. And can you tell us a little bit about the changes to the ASC covered procedure list?
Sure. So every year, CMS, primarily led by their medical officers, is looking at and evaluating procedures that may be eligible for addition to the ASC covered procedure list for the coming year. And unfortunately, once again, playing Debbie Downer role, I guess, but they had only proposed one procedure to be added to the list. And ASCA had submitted, I think, 37 codes for their consideration. We had gone to our members and done a survey to ask what procedures our members were doing on, private pay market that they thought would be safe for Medicare beneficiaries, and in the proposed rule, they only added one. In the final rule, they did increase that to 4. So there were 4 procedures that were added to the ASC cover procedure list for 2023. Probably most significant to the listeners and at least our members would be CPT code 19307. That's a radical mastectomy code. that we have been requesting for some time now. But all the procedures that we had, asked CMS for are done primarily in the outpatient space. So although we were disappointed that there were only 4 procedures added, we're excited that in the future, CMS is going to start a new nomination process where, any interested stakeholders, so all the listeners for this podcast, hopefully you'll submit codes in the future that you think should be payable in the Medicare space. Unfortunately, that process has been delayed, and so that won't start until January 1, 2024, which would be effective for 2025 rulemaking. So we have a little bit of time before that goes into place. So ASCA is planning on being very proactive in 2023. We're scheduling a meeting to go speak with Medicare medical officers in January or early February to present codes that we would like to see added. One of the primary codes that we're pushing hard for in future rulemaking, so it wouldn't be 2024 at the earliest, but one of the codes we're pushing for is total shoulder arthroplasty. It's far and away the procedure lately that's been getting the most traction and had the most requests from our members. So more to come on that, but I will just put in a quick plug to anyone listening. If you have any outcomes data from your facility, specifically on total shoulder, we would welcome that information. CMS is very interested in, seeing actual data. And like I said, how how many procedures are being performed. We can typically pull that kind of information. We have access to volume data, but they are looking at outcomes data, so they can show that there'll be safe procedures to be performed in ASCs. So any help we can get, we would welcome that.
Very helpful. And just, there's a couple follow-up questions there. From a context perspective, you said there was 4 procedures in the final rule. How does that compare to previous years?
So it's fairly consistent, unfortunately, and that's part of the reason that we wanted this new, more formal nomination process where you can eventually go on the CMS website, submit codes through a portal, and then CMS will have to respond to those codes. Because in the past, we've gone and presented to CMS, and it's kind of like you don't hear back, and then it's either in the proposed rule or it's not, and anywhere from 0 procedures added to, we did have, a couple of years where we got like 17 codes. Those were typically in years where we had like certain specialties that we're focused on. So, you may remember that a few years ago, we had some cardiovascular codes added to our list. So we got 17 codes, I think, at that time, but they were all within the same, specialty. But it's typically, between, I'd say 4 to 6 codes a year. So slow movement, unfortunately, but we are, like I said, planning on being more proactive in 2023. We kind of took a little bit of a hiatus, taking surgeons to meet with CMS medical officers during the pandemic, but we are picking that up and resuming that in 2023.
So slow but steady progress, and it sounds like, hey, at least there's line of sight into a new, more structured, hopefully more visibility nomination process. Until then, you mentioned that ASCA is continuing to help us fill that gap. How does ASCA go about determining what you guys put on your recommendation list from a CPT code perspective?
Absolutely. So we do a survey of our members every year, and we ask for them to submit codes to us that they would like to be considered. And then we always ask for all of those procedures. We also go to look at the claims data that we have access to for private payer claims, and we look to see how often those codes are being done in the outpatient setting, both ASCs and hospital outpatient departments. I would argue, hopefully most in our space would argue that in terms of safety and quality, ASCs and hospital outpatient departments are pretty much one and the same. So, we argue consistently to CMS that anything that is allowed to be performed in a hospital outpatient department should also be allowed on the ASC covered procedure list. But it's all based on member recommendations. And then in addition to that, we will include other procedures that we see that are being done in high volume in case, we just didn't hear from those folks, those doctors who are performing, other procedures. So it's usually high volume and anything that is requested from membership.
Great. And another piece I wanted to touch on that you mentioned was the outcomes data that seems to be pretty important in the CMS decisioning. What type of outcome data or outcome tracking have you seen to be most effective? Because this outcome term can mean different things to different folks, and it can be hard in terms of, hey, what really is going to hold up under the scrutiny?
It's tough too, because I think sometimes CMS doesn't even know what it's looking for. We, provided them with a couple of research studies in the past 2 years of rulemaking, specific to total shoulder, total ankle, and a spine fusion code. And it was successful 2 years ago, keeping those codes off of going back on the inpatient only list. Some listeners may remember that there were huge sweeping changes made during the final year of the Trump administration, and then the Biden administration in its first year kind of pulled back a lot on those changes. And so they were planning on adding like total shoulder, total ankle, and some spine codes back to the inpatient only list. We were successful keeping those off. And thought that, the research that we shared was probably compelling and helpful with that. But then when we shared similar research and information, this year or last year for 2023 rulemaking, it wasn't as compelling. Part of the reason that we need to go meet with CMS is because we want further guidance in terms of what is going to move the needle. In the final rule, they said that the data wasn't compelling because I guess it wasn't enough volume to look at. And then they also made this weird argument about, is it transferable across all surgery centers? And I didn't exactly understand what that meant. Like, an eye center is not going to all of a sudden start doing total shoulder surgery. But anybody who's already doing total joint replacements, I have full confidence in our facilities that those who are doing total joint replacements are safe and effective and could add total shoulder Medicare volume to that mix. So like I said, it's kind of unclear what exactly they want. And of course, the outcomes data for each type of procedure varies. So for a lot of these joint replacements, they're looking to see, infections. They're looking to see, was there a follow-up, depending on the surgery, was there a follow-up required? Really any data that we get our hands on, we share with CMS because anything is better than nothing. And like I said, it's still kind of unclear to us based on the responses that we've gotten from them in previous meetings, what exactly they're looking for.
Sure. Okay. Well, shifting gears on you a little bit on maybe more of a kind of positive glasses half full perspective. The ruling, from my understanding, does include some complexity adjustments for certain code combinations, I believe. Can you explain what the policy does, and talk about the benefit of that for the industry?
Sure, absolutely. So this was a big win for ASCs and a good starting point for this policy. So for hospital outpatient departments, for some time, they've had this complexity adjustment. So CMS takes the primary surgical code that's being done and then an add-on code that's done in conjunction with that, and they bump up the reimbursement rate because they're saying that the add-on code changes the complexity and the cost of performing that procedure. So typically for every run-of-the-mill case, add-on codes are not separately payable. They're N1 payment indicator, and there's no additional reimbursement available. But CMS has found, like I said, these code combinations. For 2023, there are 55 of them in the ASC setting for which the add-on is going to, increase that reimbursement for ASCs. So, it's a start. There are certainly other code combinations we're looking to get added. There's not really a ton of spine on there, and we know for a fact that there are a lot of spine code combinations with an add-on that certainly are more complex and costlier. So one example I've been giving is removal of thyroid. So the primary code is 60240, and there's often an add-on with that 60512 that would typically not be reimbursed under the 2022 and prior Medicare policies. But CMS has found that when those codes are done in combination, it's costlier and more complex. And so now this new C code that CMS has established is C7555, and it has a reimbursement rate of around $4,200. So basically an increase of $1,700-$1,800 because of those codes being done in combination. So ASCA is going to put out more resources. We also have some already available on our website, so you can see which code combinations are already going to get this new complexity adjustment. But as I said, we're really going to be pushing for a lot more code combinations in the future, specifically in the spine area.
Great. Sounds like something we can build on.
Yes.
Can you tell me a little bit about quality reporting? And I understand there's a linkage between Medicare's quality reporting and payments. And can you tell me a little bit about how that linkage works and what the implications are?
Sure. So I don't know if everybody who's listening realizes this, but updates to our quality reporting program are always found in our payment rule, because there could be a 2% penalty if you fail to report under the ASC quality reporting program. So in this year's final rule, there weren't a ton of significant changes. We did kind of push back ASC 11, which is this cataract improvement in patients' visual function within 90 days measure. It's one that we've been advocating against, I guess you would say, for almost a decade now, because it's really a physician measure. It's not a facility level measure. And so we'll continue to push back on that. But I did just want to let everyone know as a reminder that we have a few outcomes measures that are back in our quality reporting program as of 2023 data collection. So ASC 1 through 4, they were, the first measures that were added to our program back in 2012 when it was first initiated. So burns, falls, wrong events, and hospital transfers. Just a reminder that you have to collect data for those again. And I know we've been getting a lot of questions at ASCA, so you might get a lot of questions too. It is not claims-based anymore. So you used to submit those on your fee-for-service Medicare claims. That's no longer the case. Now you're collecting that data for all of your patients, and then you'll be submitting it through the web-based portal that CMS has next May. So just wanted to remind everyone on that. I know we've been getting a lot of questions, so I'm guessing that you might be getting some questions as well.
Absolutely. Fantastic. Anything else from a final ruling perspective, from a kind of macro topic perspective that our listeners should be aware of or keep an eye on?
I think it's just always important to know that, we are a small cog in, this larger machine. And, really there's a lot of discussions and rumblings happening right now about a complete overhaul and more significant changes to the Medicare program. I've talked with a lot of folks at CMS about this, and I would love to be part of those discussions because I think that there are definitely improvements that could be made. But, I was just listening to the MedPAC meeting a few weeks ago, and I think that they said that we are 0.5% of the Medicare spend, ASCs are. So, although we think, obviously there are 6,100 CMS certified ASCs, and we're saving Medicare, billions of dollars a year, but we're still a very small piece of the puzzle. But I think that we, do a good job at ASCA, even though we're a small piece of the Medicare puzzle, kind of hitting above our weight, or getting a lot of positives for our industry. So
we'll love it, and appreciate all that you do and all ASCA does on behalf of the industry. Kira, final question for you, and we ask this for all of our guests every week. What's one thing our listeners can do this week over the near term to improve their surgery centers?
Okay, it's a little self-serving, but ASCA is hosting our first fly-in in 3 years. And I would say, if at all possible, if you can come and participate in our, fly-in, also known as our National Advocacy Day, really that's how you're going to help make an impact, not only for your facility, but the industry as a whole, is getting in front of your elected officials and, telling them your story and how great you are. That's how we really get through to them. If that's not feasible, I would say, host a facility tour and bring folks in. I'm not a clinical person, and I could never give advice on, how to run your surgery center. I'm also not, a business person in that sense, but, what we do hear from elected officials who, go to bat for us in Congress or in your states is that really hearing your story, what you're doing, and all of the great care you're providing is, really what resonates with them and gets them to either sign on to our legislation or help, push different wins for the industry. So that's my plug. I'd love for you all to bring people into your facilities or come to DC if you have the ability.
And for folks that are interested in learning more about the Fly-In Day and what that entails, where can they get some information on that?
Sure. You can reach out to me. You can go to our website, ascassociation.org. And you can, like I said, feel free to reach out to me. Follow us on all the social media platforms. We have more information there as well.
Fantastic. Kira, thanks so much for joining us today.
Yep. Thank you.
As always, it has been a busy week in healthcare, so let's jump right in. Our first story of the new year comes from Becker's ASC Review. With the end of the year comes a bunch of articles recapping 2022 and looking ahead to the new year, and this article is the latter. Becker's published a write-up titled 5 Trends ASCs Need to Know in 2023, and here's the scoop. Trend number 1 is value-based care. With low-cost, high-quality procedures, ASCs are set up for success as healthcare transitions to this payment model. ASCs have always offered high-quality results, so this payment model will bode well for the industry. In minutes from Optum's investor meeting in October, they shared that their revenue per consumer has grown 31%, and they attribute that success to the increasing number of patients served under value-based care relationships. And if you do look at their minutes and you do a quick search for value-based care, you'll see that that term comes up over a dozen times, which is very telling. Trend number 2 is physician pay cuts. Medicare's physician fee schedule final rule will reduce the conversion factor by 4.48%, which is down to $33.06. There have been concerns that the cut will push physicians away from ASCs and to larger health systems and will also lead to declining availability of physician services. Trend number 3 is staff shortages. Now, this is not news to anybody. This is one of the largest concerns for ASCs right now. We've talked about it a couple times. There's unfortunately no secret solution here, as you can't cut corners with hiring qualified staff. And VMG Health shared that many ASCs will have to spend a quarter or more of their net operating revenue on employees alone as we look to next year. So focus on satisfaction and retention and recruitment as much as you can. Trend number 4 is physician ownership. If there are employed physicians at your ASC that are not currently stakeholders, you might want to consider including them. This will incentivize all physicians who work with you to not only strive for their own day-to-day satisfaction and good pay, but to also strive for the longevity and success of the ASC. And obviously, with more cases comes more revenue and more stability. Trend number 5, last but not least, is stagnant reimbursement rates. ASCs are paid much lower rates than hospital outpatient departments for the same exact procedures. So you need to keep a close eye on payer behavior and really build one-on-one relationships with your payers as much as you can. And there you have it. Those are the 5 trends from Becker's to keep an eye on as we are officially now in the new year. Our next piece of news comes from Outpatient Surgery Magazine, and I personally think this story is really cool. An airport-style security scanner at the University of Iowa hospitals and clinics is saving tens of thousands of dollars worth of valuable instruments from accidentally entering the waste stream. After each surgery, bags of trash are removed from the OR. They are run through environmental services, placed on a conveyor belt, and scanned. Each bag is numbered to identify the room and surgery from which it came from, and if the scan detects an instrument, a nurse is called to identify it and process it correctly through the sterile processing department. This idea alone has recovered $35,000 worth of lost instruments in its first 9 months. So, as we're constantly thinking about ways to reduce waste and save money, this idea checks both of those boxes. Now, I'm not sure how much the conveyor belt cost, but I'd imagine with an average savings of roughly $3,800 per month, it will pay for itself pretty quickly if it hasn't already. Our third story comes from Med City News, and they put together a piece on 7 rules hospitals should follow when adopting new tech. And 5 of those rules really apply to ASCs as well. If your surgery center is considering adopting new technology in 2023, whether it's patient texting or an EHR or a patient estimating tool, keeping these rules in mind will help you significantly in the implementation process. So, first, planning should begin during the sales process. Work with your vendor to set clear expectations, timelines, implementation plans, any hidden costs, and everything else. Don't hold back with your questions and don't hold back pushing your vendor for clear answers until you're comfortable with them. Tip number 2, clearly define governance structures. So by this, they mean just organize a leadership team for the project and make sure members of the team have clear roles and responsibilities. Now, that might seem like a no-brainer, but it shouldn't be something that's just assumed. We want this written down, and everyone needs to buy in. Tip number 3 is always communicate. Everyone involved should have a clear understanding of who's doing what at all times and why they're doing it, and create an actual communication plan and provide regular updates. Tip number 4 is to prioritize stakeholder alignment. Leaders of both your ASC and the vendor must be transparent with each other, express buy-in, and commit to success. Without that stakeholder alignment, the whole process could fall out of whack. And the last tip here, training is a necessary investment, and I couldn't agree more. This is a huge one. We just did an episode on nursing informatics, which kind of ties in exactly to what this tip is saying. Without proper training, end users usually don't feel comfortable adopting a new technology or won't be satisfied with it. So early on in the tech adoption process, you should designate who is responsible for creating and delivering training materials and assign power users to each department. Without those power users and without proper training, the care patients are receiving could be impacted and patient safety could be impacted. So make sure you invest in training. And to end our new segment on a positive note, Dr. Steve Lomé saved 2 lives during a half marathon recently. Dr. Lomé was running the marathon himself when he saw Gregory Gonzalez, a fellow runner, fall and hit his head. He immediately began CPR until an ambulance arrived. Then at the finish line, another fellow runner, Michael Heilman, also fell and hit his head, and the same chain of events occurred. Dr. Lomé began CPR until an ambulance arrived. Both men ultimately had blockages that led to their cardiac arrest, and they received stents in their coronary arteries and are perfectly fine. And the 3 men plan to run the half marathon together in 2023. And that news story officially wraps up this week's podcast. Thank you, as always, for spending a few minutes of your week with us. Make sure to subscribe or leave a review on whichever platform you're listening from. I hope you have a great day, and we'll see you again next week.